Okay. Why don't we get started with the afternoon session? Enjoyed your box lunches and slight change of scenery. We proceed with our keynote. Dawn Hunter is the director of the Southeast region of the Network for Public Health Law, where he's spearheading outreach initiatives with a number of different partner organizations, including the Healthy Democracy, Healthy People Initiative, and the Basis of the Public Health Crisis Research Collaborative. If you just want to see a great website, go look at the Healthy Democracy, Healthy People site and their democracy index. In the past, she's had a variety of experiences in a variety of sectors. She's been at the Thatcher Health Leadership Institute, or been a member of that, and worked on the Google.org Health Equity Task Force, which advised on the development of a recently released health equity tracker at the Thatcher Institute. Before joining the network, she was Chief Innovation Officer at Foundation for a Healthy St. Petersburg. And before that, she was at the New Mexico Department of Health. So she's been on all sides of the public health work, funding, advocacy, innovation side. But the reason that I was so happy to have that Dawn was able to come is that she's just one of those people. The very first time I saw her on a Zoom or a meeting or something, she said something and said, "Wow, that's really smart. Or, that's really cool. And I got to watch that." And then it just kept happening. We're on a lot of calls together, and partnerships and coalitions together. Usually, whenever she came her turn, came to talk, and I somehow got a word in edgewise around me. It was always really, really innovative and interesting. And so I'm glad to have her here to talk to us about ways to move forward.
How is everyone? Okay. Can you hear me okay from my good position? Yes. Okay. Great. Well, I want to start first by saying thank you to Sarah, to Pooja, to Scott in particular, and to Temple Law for the opportunity to be here at state today. I also want to say that, and I said this to people at the welcome reception last night, this is my first time being in person talking to people like this since like early 2019. So it's both very exciting and also slightly terrifying. But I don't have slides today, so I've spent a lot of time on Zoom, as we all have, and I thought I would just talk to you. And I want to start by saying my name is Dawn. I am a Black biracial woman. My pronouns are she, her. And I grew up in the Air Force. Both of my parents were in the Air Force, and I spent most of my life in a relatively rural and conservative part of that state. And I share this because this experience shaped my life very much and still does today, and I'll talk more about that in a moment. But when I thought about what I wanted to talk about today, I wanted to focus on lessons and what it means to center health and racial equity in public health practice. So I started just by looking at the agenda and the topics, right? Policy, how the system works and what it costs, who is driving or blocking reform, centering health and equity, and identifying new paradigms and frameworks. So what I hope to do in the time that I have is to tie together some threads and draw on the connections to my own personal and professional experience between policy and practice. I'm a very action-oriented person. I'm the person that's in meetings, and if we don't leave with action items, I'm like, why was I even here? So I hope to leave you with some action items as well. And so I'm not going to give you examples of inequity. You're hearing that you heard those this morning, you're hearing some more this afternoon. I'm really going to focus on some high-level observations and practices. So I started on this path that I'm on, frankly, because of my own upbringing. I grew up in a household that was physically violent, and there was a lot of verbal and mental abuse. But I had school, I had teachers, I had community members who were there for me and who were a parent for me when I needed one. And I wanted to help other children who were in similar circumstances to have the same opportunities, the same support that I had in order to succeed in life. So that's actually how I started out my career in child protective services many years ago now. I worked in a wilderness reform camp. I worked in residential foster care case management, and foster care adoptions. And I saw a lot of interesting things. One of my very first cases was a child and proxy case. I had a former professional athlete and his wife who struggled with substance use. I had a case where 10 siblings made it through the system at various points in time. I also saw children to their forever homes, which is an amazing thing. But I also lost a foster child to a horrific car accident. Most of my cases were not physical or sexual abuse cases. They were actually neglect. And most of the cases I had were children and families of color. And all of the things that families struggled with then, that I was helping them with as a caseworker, are all the things that I know now and didn't know then that we call the social determinants of health, right? So how do I get a job? How do I get transportation to and from work and school? How do I recover from addiction? How do I return successfully from incarceration? Relative caregivers who are trying to do the best they can with very limited resources. So these are all things that we now know are an important part of a holistic approach to healthy and resilient families. And I want to share one example of a case with you. And I had a young woman who, I had 3 of her siblings on my caseload, and she eventually, we eventually had to remove her from her mother. We placed her with a relative. And it started out okay, but then she would give us reports that there were guns in the home, there were drugs in the home. You know, she didn't feel like it was the safest place to be. And I would do like a good caseworker would do, I would do unannounced visits, I would call an investigator to go with me, we would go investigate and search the house together. We never really saw anything. And then I started getting reports from school that she was showing up, she wasn't wearing, you know, clean clothes that day. Or she was a young Black girl and she had, her hair wasn't being taken care of. She had sores on her scalp, and I would have to go take care of these things. Until one day she ran away. And so when children in foster care run away, they end up hanging out with their caseworkers at their office until we can find any placement for them. And so I said, okay, well, clearly we're not going to send you back there, but I do need to go to your relative's house to pick up some of your things. So I did, and I still remember this to this day. I pulled up to the house, and there were these black SUVs there, and people with black jackets and yellow letters, and they were conducting a raid. They were, in fact, drugs in the house. And when I went in, I showed them my credentials. I went in, and the relative was sitting there in handcuffs. And I was like, I don't know how we didn't, see this. I mean, all the times we've been in this house. But thankfully, we got her out, and we picked her with a new relative. But that relative lived in a different part of town, and also didn't have children of her own. And so I was in the position to have to go find a new mattress, so that this kid had a place to sleep, find clothes for her, enroll her in a new school. We eventually got her a new mentor, a mentor to help her through what she was going through. And I keep in touch with a lot of the kids that were on my caseload and at the time, and now they're all no longer children, and they're also, some of them are in their 30s, which is like, but I don't know about this particular girl, what happened to her. But I share this story with you because there are tens of thousands of young children like her who are not a part of Child Protective Services, who are having these kinds of experiences every day. And I think it's even more pronounced now. We saw the research come out about COVID and the loss of caregivers, especially for Black and Hispanic or Latino children, and what it means to go through that trauma and that transition. And I share this because it's important to understand how to connect these lived experiences to, and how people live firsthand, right, to the policy solutions that we want to identify. So that's my first lesson of today, is really to connect these discussions that we're having here to people and their experiences. So I eventually left the system because I felt like what I was doing was kind of futile. We were asking parents to check boxes. Did you take your anger management class? Did you do your parenting class? Are you seeing your counselor? We report that back to the court. But we weren't really addressing whether or not they had the supports in place that they needed to actually be successful when they didn't have a caseworker coming to their house all the time. And so I ended up in my career there in foster care adoptions. And what really shifted me to policy work was this disillusionment with finding children their forever homes. It turned into, in my opinion, a race to close cases and to finalize adoptions. We had to find kids their forever family, right? That's the motto of our state. And many of these placements were successful, but some of them were not. And our work was really driven by the state level policy and this directive that was not always, in my opinion, in the best interest of children and families. So I can give you many examples of these failures, but one is this. And it was one of my last cases. I had a child who was part of a sibling group of 5. And she was 13 when I got her case, and she had been with the same foster parent since she was a toddler. And the foster parent wanted to keep her, but like many foster parents at the time, she did not want to adopt. And there are lots of reasons for that. But in the end, we ended up removing her from that placement, which had basically been her forever home. We placed her with all of her siblings, with a woman who had previously adopted. We spent months and months doing home visits, doing supervised visitation, having in-home counseling, making sure this placement would be successful. I finalized that case, and then I actually left child welfare, but I ran into the mom a year later and asked her how she was doing, and she said she had given all the children back. And I thought, this, along with a few other experiences I had, I thought, this is not what we're trying to accomplish, right? I wanted to be able to do something at a systems level that would really prevent these children from experiencing this particular kind of trauma and disruption in their lives. And I really wanted to focus on how do we create the conditions for children and families to be healthy in the first place? How do we keep them together? One of the big lessons I have from my time in Child Protective Services is that kids want to go back to their parents no matter how bad their parents were. So if we know that to be true, then we need to do a much better job of supporting parents to be parents and supporting families to stay together. So I did a lot of things in between and a few years in between, but ultimately I ended up in state public health at the New Mexico Department of Health. And that's the next kind of major experience I want to share with you. I was in a governor appointed position there, and in that position I was able to do some really amazing things. One of the things I was able to do was help to write and pass the an update to New Mexico's Public Health Act that was signed into law in 2017. I was mostly excited because it was actually cited in some executive orders during the pandemic. But what I really want to share with you is more of the day-to-day work that we did at the health department and what it means for us as we have these discussions today. For state health departments in particular, doing what is best from a public health perspective can often be outweighed by political expectations and priorities. I think we all know that. We've seen that during the pandemic. We were often asked to fund projects and programs that weren't always specific to public health. We had to make budget cuts. We had to go without necessary equipment and personnel, and not because these were the best or the right decisions, but because that was what was negotiated. And there's one specific example tied to our current environment, and that's that even pre-pandemic, we struggled to have competitive pay for our public health workforce. We often had high vacancies and difficulty recruiting. We suffered from dissatisfaction with management among our frontline staff and a lack of training and professional development opportunities. And these problems have not gone away, and in fact have probably gotten worse. But there are two lessons from my time at the Department of Health that I wanted to share. And the first is that sometimes a lesser version of an idea gets negotiated, and we have to be prepared to make that idea work while we keep striving for the thing that we actually want. The second lesson is that no matter where you work, you have to have a workforce that is supported and equipped and resourced to actually do the work. We can't talk about impacting structural racism when we have people who are experiencing racism and discrimination in the institutions they work for, the same institutions that are claiming that they're trying to make change. And we can't make change when our workforce is disgruntled, they're dissatisfied, or even worse, they're just struggling to get by. We can't ask people to give when they are depleted themselves. So now I'm going to talk to you a little bit about some of my current work projects that you heard Scott describe, some of those projects, and how they relate to centering health and equity. And the first is that at the network, we did a series of focus groups and we issued a racial equity survey towards the end of the summer. And the survey was really getting at an understanding of people who are doing racial equity work. What is their experience within their organization, and what do they feel like are barriers or challenges to doing racial equity work? We had about 379 responses to the survey. We had about 30 people in focus groups, and these respondents were from all kinds of sectors and all kinds of positions, frontline to executive leadership. And so what did we find? We found a lot of things. I'm going to share a few with you. 83.4% agreed or strongly agreed that addressing racial equity was a high priority of their organization. You hear that, you're like, hey, that's pretty good, right? But only 68.6% agreed or strongly agreed that their organization takes meaningful action to address racial equity. Clearly, there's a gap. We also had some results that told us that health equity is a much more prevalent concept than racial equity and has more traction in health departments or among our partners working in public health. 42% agreed or strongly agreed that the organization allocates sufficient resources for racial equity initiatives. And then when we asked about whether or not the organization allocates sufficient resources for engagement and outreach in communities of color, just over 31% said they thought that was true, right? So there's a commitment, and we're not putting the resources toward the commitment. Some other interesting results. The workforce not reflecting the demographics of the community served. So when we asked that question, only 39% of respondents said that they thought that was true. And when we asked about the biggest challenges when it comes to health equity, the top 5 in order were infrastructure, funding, recruitment or hiring, workforce development, training or education, and promotion or retention. Organizational policies and practices came in 6th. And I share these results with you for 2 reasons. The first is that there is a disconnect between health and racial equity, and we need to do more to educate our workforce on what we are even trying to accomplish. And the second is that we have to understand the barriers to implementation faced by agencies and organizations doing the work. The best laws and policies in the world mean nothing if we don't have people to educate others on them, to implement them, to enforce them, and to believe in them. So one of my other projects you actually heard Claudia Gonzalez talk about, and you've heard mentioned a couple of times since, is racism and public health crisis. I read most of the 200 declarations that are out there, and we have issued a couple of issue briefs. I'm not going to talk about those today. They are available on the network's website. I've also been facilitating a research collaborative with partners working on racism from a public health perspective. And we have a few goals, and among those goals are to amplify the work that we're doing as partners and to create shared opportunities for research and practice. Importantly, though, we want to provide guidance to communities trying to implement these declarations or trying to take action on racial equity. And we want to contribute to the national narrative on racism as a public health issue. And we hope that doing so as partners, it will have a greater collective impact. And there are lots of really interesting differences when you look at these across regions. So California mostly, but in the western part of the country, there's a lot more discussion of trauma and healing. In the eastern and southeastern region, there are a lot more references to specific historical events, the history of the slave trade and events associated there, and a large number reference police violence or list specific victims of police violence. You can read more about these findings at our network website, but I want to share about this work is this. We've conducted 2 workshops now where we do a deep dive into the language of declarations, and we select a couple of different random ones from across the country. And there are 2 things that stand out to me from those discussions. The first is that declarations are often aspirational, but non-committal. So this is not really surprising given politics. It's sometimes very hard to get these things passed. But the perception is that here's this policy-making body, a city council, a county commission, whoever it is, they have the power to actually do things. But what they're doing is saying, we're going to encourage, we're going to try, we're going to support this effort. They can do more, and they have the power to do more. The second is that community members were often not a part of the drafting or passage of these declarations. And while a declaration definitely holds weight on its own, it really raises the question of how community members perceive these declarations and the work of racial equity. One example that has been brought to our attention is some of these declarations say, we're going to use the Government Alliance on Race and Equity framework, or the ER framework. Like, I work in public health, I'm like, yeah, that's great. The ER framework's pretty good. But if you're a member of the community, you have no idea what that is. And what does it matter to you if they use the ER framework? It doesn't. I was many years ago, I'm part of a behavioral health panel, and we had a person with lived experience there who was a peer counselor who was talking about her experience going to her own counselor. And she said, when I go to my counselor, I don't say, hey, I need some help with my social determinants of health, right? Nobody talks like that. And so I think there's a real disconnection in the way that we talk about problems versus the way people in the community talk about their problems. The community has to very much be a part of these efforts, if not leading them, and certainly has to be part of implementation if they weren't involved in the design. But involved community as really as possible. So as I transition talking about community, I'm super excited to hear all the talk about civic engagement because I do a lot of work in civic engagement and the connection between voting disparities and health disparities. So we know that people in poor health are less likely to vote. This leads to less inclusive health policy that perpetuates poor health and continues to depress voter turnout. Engagement, though, in the democratic process is really important for shaping better health policy and for shaping the social determinants of health. So as Scott mentioned, you can learn more about this in the Health and Democracy Index. It's one of my major projects. It is really a cool website. It's got lots of cool data. It's very interactive. It's one of the things I'm most proud of that I've done. And what I want to say is part of our efforts when we think about all of the legal and policy interventions that are being discussed here today must necessarily include enacting laws and policies that allow people to fully participate in our democracy. Greater civic participation is necessary for having a just and multiracial democracy. So 2 examples I want to share with you of relevant policies: Medicaid automatic voter registration, or AVR. So a lot of people are probably familiar with being able to register to vote through your state's Department of Motor Vehicles, maybe, hopefully, some people, okay. So Medicaid and other federal agencies, Medicaid agencies in particular, are already required to provide assistance with registering to vote and assistance with that process. And it's frankly just something that's underutilized. So right now, 6 states are trying to implement Medicaid-based registration. And it's important because you can reach a population that is more likely to be left off of the voter rolls. Older people, low-income people, people who lack access to transportation, and they're more likely to be people of color. 60% of Medicaid enrollees are people of color. 60%. So by addressing, giving opportunities to register to vote, we can address both voting disparities and health disparities in this population. But this is also a lesson in utilizing existing programs and contacts with people who we want to serve and uplift through better coordination and leveraging existing laws to accomplish health and racial equity goals. The second kind of example I want to give, just this week, the Eviction Lab from Princeton put out some research that showed that evictions suppressed voter turnout in the 2016 election and likely diminished the power of low-income Black and Hispanic or Latino voters. So all of these determinants, housing, healthcare, et cetera, are interconnected, and we have to think about the ramifications of policy across all these sectors. So the last big initiative I'm involved in at the Network for Public Health Law is messaging. How many people have done or seen the Becoming Better Messengers training that we offer? Okay, so I'm gonna make sure you all get the link after this and you can go check it out. But it's a training that focuses on messaging for public health advocacy, really. Part of it, what we heard somebody say earlier, how we build political will. I have been bringing more of an equity component to that training, and there are 3 lessons that I want to share with you from that. The first is the intuitive elephant. So if you're in a training, you'll hear this, but basically it's the idea that 90% of what we do is driven by our intuition, and 10% our rational brain. I was listening to a Hidden Brain podcast episode, and I was telling some folks about this last night. I was talking about innovation. And one of the things that was said in that podcast is, we prefer what is familiar to us over what is not familiar. We prefer systems that we are in over systems, new systems, no matter what the benefits or value are to us. And the bigger and more radical the change and difference from what we have and what is being proposed, the more resistant we are. And so we see this now with racial equity. I think this is really relevant for the question that was before the break about why do some of these initiatives fail? And it's because I think part of the answer is that we're asking people to change the entire system that they operate in and have a different way of doing things. And that makes people resistant. So think about the range of interventions that you design. We want the big, scary things, but we also want things that we can get done and that will also make a difference. Part of this messaging lesson is know your audience. And so I talk about this a lot, but then I'm going to reference this Hidden Brain episode again because it was really just amazing. But they were talking about a company that sold custom couches, and they had a lot of interest in this. People would come in, they would design their couches, and they would be really excited, and then people would buy them. So they were like, well, what do we need to do? Do we need to lower the price? Do we need to give people better design options? So they hired a company to come in and actually talk to the customers, surprise, about what it is, why they weren't buying the couches. And what it turns out is that people didn't know what to do with their old couch. So they set up a delivery service that if you ordered a couch from them, they would pick up your old couch and take care of it for you. Sales went through the roof. So why does that matter? I think we often forget that if we want to know the answers to the barriers that people are experiencing, we need to ask the people, right? If you want to know what barriers people have, go out and ask them. If you want to know what people think will make their community better and healthier, ask them. If you want to know what people in the community think, how do they define racial equity? Go ask them. It's probably not what you think. And it's probably something that's even more simple than what all the ideas that you have come up with. The last part of the messaging thing that I want to emphasize is how we talk about community. And I've done a lot of reading on othering and belonging. And I find myself often, and I'm doing it now too, saying them or people of color or the community. But I'm that person, right? I'm a member of the community. I'm a person of color. So we are all interconnected, and I think we often kind of talk about solutions, talk about interventions, and remove ourselves as part of the community that's going to be experiencing the impacts. But we have to remember that we are also part of that community that has to be implementing and assessing and monitoring the law and policy interventions that get put into place. But we also need to recognize and adjust for power differentials, right? So going into that knowing that we are in a particular place of privilege as people who have skill in designing these solutions, but also that we are people who want to see the benefits for our own communities. So as I end, I have a handful of takeaways that I wanted to share with you. The first is that equity is a process and not an outcome. Dr. Tamara Jones has said this. I often talk about this as equity being a framework and not a task. One of the things that we learned from our focus groups in the equity survey that we did is that people said they don't have time to do equity work. And we're responding to COVID. We've got a crisis, financial crisis. Yeah, we have to make it feasible and appealing for people to engage in racial equity work. And we have to address each of the levels of racism, individual, institutional, and structural, because we can't get rid of racist institutions if we still have racist people going around creating and running these institutions. I saw on Twitter something the other day that said, clean up your house before you invite others in. I think it's an important point to keep when we're talking about racial equity and our work as institutions. And I want to draw attention to the work of our colleague, Rukai Yerby at St. Louis University School of Law. And she and her colleagues have found that organizations that have made commitments to address racial equity actually have found that they need to do more internal work before they can go out and create change in the communities that they serve. So it's great that you have like a mission statement that says you're going to advance health equity and racial equity, but it's not great if you haven't built your own capacity to actually do that work and you don't have a workforce that supports that work that you're trying to do. The second takeaway is don't focus on people, focus on systems and conditions and places. I often in messaging training talk about diabetes as an example. So you hear, if you work in public health, you might hear American Indians have higher rates of diabetes or African Americans have higher rates of diabetes. And that may be true, but what is also true is that diabetes is more common in communities that don't have access to healthy food, safe spaces to exercise, don't have safe neighborhoods. That's the problem. So we want to start out by talking about that, and then we can have a conversation about the people who are impacted. I also want to propose that instead of asking about deficits, that we ask about strengths. What has allowed communities of color to be successful? Identify that, not from our perspective, from the perspective of people in the community, and then let's build on that. The next lesson is take time to understand why things fail. I'm from St. Petersburg, Florida. We just elected our first Black mayor in the election last week. Very excited about this. And we also had several charter amendments that were related to racial equity, including establishing a chief equity officer and dedicated racial equity funding for the city. Those charter amendments failed. And I don't know that people are spending a lot of time understanding why they failed, but we absolutely 100% should be figuring that out. And KFF released a survey this week that talked about adults who believe in vaccine misinformation. And one of the pieces of misinformation is that the government is exaggerating about COVID deaths. And this wasn't just conservatives, it was kind of across the board, people who believed in misinformation. This was one of the top ones. But that article didn't really say why. And I think that's a question that we need to ask. Why do you think that the government is exaggerating deaths? And it's not just because of Fox News, right? There's something deeper going on there than that. And so ultimately, we're seeking to understand what creates barrier to action for people. And we want to ask why, and we want to keep asking why until we understand. And this applies especially to racial equity because a lot of people are opposed to it. But we need to understand why they're opposed. And we may find that they're not actually opposed, which leads me to getting comfortable with being uncomfortable. I was talking to Ed Ellinger, who is a former state health commissioner in Minnesota, and we were talking about racial equity, and he said, Don, white people want racial equity too. And I don't know why that stood out to me at the time, but I'm like, yeah, I guess a lot of people might assume that that's not a common thing that people want. But it is, right? We all want an equitable world. And then I remember being at a speech with David R. Williams from Harvard, and he said, racism places an upper limit on the health of white people. And I was like, I've never heard this before either. And so it really stuck with me because I think it goes to, many people may have heard of Heather McKee and her book, That Some of Us, but it's really about how racial equity is not a zero-sum game, right? Somebody doesn't have to lose for somebody to win. We can all win when we have more equitable laws and policies and a more equitable society. But this goes back to what I was saying, it's like when you push on people, they're going to push back. And the stronger you push, the stronger they push back. And messaging, I often say, you're not going to change the behavior of people who are already on your side. Like you're not really trying, that's not who you're trying to reach. You're trying to reach people on the fence, but you really have to be thoughtful about the message that you design, because instead of bringing people to your side, you might make them more resistant to your message. And so keep being, but the important thing is that we keep having these conversations. I call them uncomfortable. I don't know how many other people have been through courageous conversations, the training, but that is also, I think, a better way to describe it, is that keep having these courageous conversations about race. So the next and probably one of the most important takeaways, I hope, is how do we really meaningfully engage the community? And so we see this a lot. I've seen this a lot in my work on the Health and Democracy Index, on the declarations of racism as a public health crisis, through our messaging work. And the important lesson here is that people want to feel like they created the change. You hear these terms, co-design and co-ownership with communities, and those things are valuable and important and have to be done. And so what I would want to say to you today as an action is take your policy to the people. You have a solution, take it to the people who are going to be impacted and see if they really think that's the solution. Going back to the Hidden Brain podcast I was talking about, it was about innovation, and they said, a core component of innovation is seeing things from the perspective of other people. That's why I shared my experience in child protective services. It's important to know that change comes from understanding these new perspectives. And this last piece here, it's not our job, I heard me say this recently, it's not our job to bring the magic solutions to the community. And I wanted to share this quote from Adrian Dominguez, who's the Director of Informatics and Epidemiology at the Urban Indian Health Institute. And he's one of our network board members. And he said this at the All In Data conference this weekend. He said, do not come to us because you think we have all the problems. Come to us because you think we have the answers. So the last kind of bit I want to talk about is just trauma, both societal and individual. One of the steps to achieving health equity that Dr. Kamara Jones has put out is that we have to acknowledge history and remedy past injustice. We see this acknowledged very clearly and often articulated very well in the declarations. They're strong on the why and they're less strong on the how, but it's in there. And I share with you some of my own experience with trauma in my life. And I remember talking to an uncle of mine recently, fairly recently. We were talking about being resilient. And he said, trauma is not the way we want to go about being changed, but it happens to a lot of us. So to that I say, what are you doing as professionals and as people to engage in self-care? In order to care for our communities, we can take better care of our communities and we take better care of ourselves. So just remember that, and remember the experience of trauma, not even just childhood, right? I was talking about childhood trauma, but how many people have so many of us lost during this pandemic? How many people have experienced job loss? Or how many people that we know have been affected by that? Those traumas don't go away, they touch us forever. So the last takeaway is be patient. Change takes time, and if you work in public health, you know this, right? Population health indicators don't change very quickly. I wrote a top 10 article for American Health Law Association for 2021. It was published in January. I think I submitted it around this time 2 years ago. And I was looking at it and I was like, oh, you could basically change this to 2022 and it would still be relevant without really having to update any of the information. And that's because it takes time to figure out what your plan is. It takes time to put resources to it. It takes time to really kind of take meaningful steps. And so I would say, don't be daunted by that. It is not going to happen overnight. And so here are my concluding thoughts. Did I have a time sign come up yet? Yeah. Okay, so I'm going to wrap this soon. I'm going to wrap this now. Okay, so my concluding thoughts and takeaways. Our goal, I think, is to help people to create change, right? And provide them a framework to engage in the behavior that we want to see. But not even that we want to see, that they want to see. We are part of the community, and so the other thing I would ask you is, how are you working toward greater health equity in your own communities, not just in your work, but as a member of your community? I do pro bono myself. I have since before I was in law school. I did a lot of volunteer work, but I volunteered for the Florida Rights Restoration Coalition, helping people trying to get their voting rights restored. I volunteer in an Amendment 4 clinic, this is based on Florida's Amendment 4, helping people who are trying to get their driver's licenses reinstated. So I appreciated that discussion this morning. I also have volunteered in the housing clinic. We have 2 in my community. One is COVID specific, one's non-COVID specific. I work in the non-COVID housing clinic. And all of this is important because it helps, I think, to better understand the issues that people are actually facing. And I think that's what I started out my talk kind of trying to emphasize. And I will share one last example. Is my mother-in-law, talking to her about people losing their voting rights because they have felonies. She said, well, I think that's right. People with felonies shouldn't be allowed to vote. And I said, well, did you know? You can get a felony for driving while your license is suspended or revoked. And if you're a habitual offender, you just keep getting more felonies every time you get pulled over. And she said, no, I didn't know that. I said, yeah, so we have people who can't vote because of basically a hyper traffic violation. Like, that's a problem. And also, if you've ever tried to help somebody get their driver's license suspensions removed, it's not an easy process. So it's like we put a system in place and then it's terrible, right? It's terrible to get out of. So the last thing I kind of want to say is, what is our end game? People are not going to stop being racist. Laws that seem really great today may turn out to be ineffective and even harmful tomorrow. So we need to be really clear about what it is that we want to achieve and what success truly looks like. It may mean that there are just some people who are not on board and that there are just some things that we can't accomplish, but we have to be really clear about what it is that we hope to accomplish and monitor what we're doing to see our progress or lack thereof. There are lots of experts, obviously, in this room and in the communities that we work with, but there are also experts in your communities. So go out and talk to them. Learn about how they live, learn about their perspectives. And then the last quote I will share, because I like Netflix, is from Colin Black and White. Just because the rules are changed doesn't mean that hearts are changed. And I think that's important. When we talk about this today, we have to change people's hearts. We have to understand their hearts, and we have to speak to their hearts for law and policy change to be truly meaningful. Thank you. Thank you for the extra time.